Hello, my name is Alvaro Agusti. I am a pulmonologist working in Barcelona, in Spain. And it is a pleasure to be here with you today to talk about a topic which is very close to my heart, treatable traits, the changing paradigm. Let me start by presenting my disclosures. I work with a number of companies, including Cipla, and I want to express my gratitude to Cipla for inviting me today to talk to you. I don't work with the tobacco companies. I am the chair of the Gold Initiative. I don't think that any of these has any conflict of interest with my presentation today. So, treatable traits, the changing paradigm. I'd like to address with you today three topics, three questions. The first question is, why do we need a new paradigm? It's important to understand the reasons of this new paradigm before moving into it. The second question is, what are treatable traits? What are they? And third, and importantly for your clinical practice, the third question is, how do we use treatable traits in practice? So these are the three questions that I'd like to discuss with you today. Let me start by the first one. Why? Why do we need a new paradigm? And the answer to this question is that obstructive airway diseases, please note that I am not talking only about COPD. I'm talking about obstructive airway diseases in general, are complex and heterogeneous. I am sure that you have read this many times. Oh, COPD or airway diseases are complex and heterogeneous. But perhaps you have not asked yourself, what does complex mean here? Is it the same thing as heterogeneous? I believe these are important questions. So let me tell you what I think. Complex indicates that these diseases are composed by several elements, not one. It's not everything about airflow limitation. There are more things. For instance, exacerbations, symptom perception, comorbidities, and others. And very importantly, these different elements do not have linear relationships. They have non-linear relationships. If these relationships were linear, it would be easy to predict one element from another element. But they are not linearly related. You see patients with the same FEV1, for instance, with frequent and infrequent exacerbations, just to give you an example. So that's the meaning of complex. Do you think that heterogeneous means the same thing? Well, in my mind, the answer is no. Heterogeneous means that not all these elements are present in all patients, or even in the same patient, they might not be present at all time points. They may increase or decrease. So they have a dynamic component. So this is the reason why a simple paradigm, let's say FEV1, is not enough to describe this complexity and this heterogeneity. More than 10 years ago, there was a first attempt to address this complexity and heterogeneity. And that attempt, what was at that time, a number of investigators, including myself, as you can see, described as the future of COPD. That was 2010, 12 years ago. And we thought that phenotypes were the way forward to address complexity and heterogeneity. In that paper, we describe or define what a clinical phenotype was. And we said that a clinical phenotype was a single or a combination of disease attributes or traits, if you want, that describe differences between individuals with COPD as they relate to clinically meaningful outcomes. Having blue eyes is a phenotype, but it is not a clinical phenotype because it doesn't has any relationship whatsoever, at least that we know today, with, for instance, symptoms or exacerbations. So that is what we proposed 12 years ago, a clinical phenotype. And if you want to present this concept graphically, what we said at that time was that in this diagram that tries to encompass all patients with COPD in the world, each circle is one patient, and each color describes one of these traits. Imagine, for instance, that red is very severe airflow limitation, green is exacerbations, blue is very highly symptomatic patients, or yellow is comorbidity, whatever you want. So the concept of a phenotype, of a clinical phenotype applied to this universe was very simple. You just simply put together green with green, blue with blue, red with red, yellow with yellow, and these are the phenotypes. The problem we realized a few years later was that life was more complex. Real life was not that simple. Real life was like this. Many patients have more than one color, more than one trait. Yeah, there are some of them who had only one color, but many have 2 or 3 or 4. And that was actually the birth of treatable traits. This concept evolved over 1 or 2 years, and it was finally published in 2016 in this paper in the ERJ by a number of well-known investigators in COPD. Treatable traits, a strategy towards precision medicine of, please note, chronic airway diseases, not necessarily COPD. We can talk about asthma, bronchiectasis, or other airway diseases, or other diseases, actually. There have been many papers published in the literature using this same concept for other diseases since this initial description. So this is why. Why do we need a new paradigm? We need a new paradigm because of complexity and heterogeneity of airway diseases. This would be the best way to address this complexity and heterogeneity in an individual patient in your clinic. So, treatable traits, what are they? As I just told you, in that paper in 2016, we proposed that this was, a precision medicine strategy for the patients, for the management of patients with airway diseases, which is label-free. We don't care about COPD, asthma, ACO, whatever you want. I mean, these are complex and heterogeneous diseases. And this strategy is based on the identification of so-called treatable traits in each patient. These traits can be identified based on phenotypic recognition, this is clinical presentation, and or on deep understanding of critical causal biological pathways which is what we call endotypes, using validated biomarkers. And I'll show you some examples later on. Very importantly, remember the colors. Treatable traits can coexist in the same patient and can change with time. Spontaneously, maybe the disease is worsening, is progressing, or as a result of an efficacious treatment. We call this treatable. That doesn't mean that all of them are treated, can be treated today. Of course, many of them have currently available treatment, but some of them, for instance, neutrophilic airway inflammation, does not have a clear-cut treatment today, but these identify clear targets for research. You might know that we propose that there are 3 basic domains where treatable traits should be looked for in any individual: the pulmonary domain, the extrapulmonary domain, and the behavioral and social risk factors, as I will detail in a minute. The pulmonary domain. Here you have a list of about 10 potential treatable traits in the pulmonary domain. This does not pretend to be a comprehensive list. There may be more. These are simply more the most frequent and potentially relevant ones, according to the author's opinion. Of course, airway smooth muscle contraction, bronchoconstriction, airway inflammation, particularly if it is of T2 type, eosinophilic, chronic bronchitis, bacterial airway colonization, bronchiectasis, cough, chronic respiratory failure, pulmonary emphysema, hypertension, or emphysema, and probably more. You might think about more. The important thing here is that each of these traits has a specific treatment. If the problem is bronchoconstriction, you use bronchodilators. If the problem is eosinophilic airway inflammation, you use inhaled steroids, or sometimes type 2 biologics. If it is chronic bronchitis, smoking cessation, macrolides, PDE4 inhibitors. If it is bacterial colonization, macrolides or tetracycline, and so forth. So each of the traits in the pulmonary domain has a corresponding specific treatment that you should consider using if the trait is present. Same thing happens for the extrapulmonary treatable traits, including rhinosinusitis, deconditioning, cachexia, obesity, cardiovascular disease, and others. Each of them, again, has its own treatment: topical steroids or surgery, in case of rhinosinusitis and polyps, rehab for deconditioning, diet, physical activity for cachexia, obesity, cardiovascular disease, and so forth. Finally, a very important domain within is this behavioral, social, lifestyle factors domain. Poor inhalation technique, that's a treatable trait, a very important treatable trait with appropriate education. Of course, non-adherence to treatment is the patient does not use the treatment, there will be no treatment effect. So reassurance of safety, education, and very importantly, periodic checkup. Of course, smoking, cessation support, and so forth. So you see that there are a number of treatable traits in 3 different domains. Each of them merit treatment if you find it after careful searching. So this takes us to my last and final question today. How do we do this in practice? How can we apply this strategy in practice? Let me tell you that we are already applying it in practice. This is GOLD Recommendations 2021. It already says that, or it already recommends that for follow-up treatment, you should consider the predominant treatable trait you want to target, dyspnea or exacerbations. And even more, if you want to target exacerbations, GOLD recommend the use of a biomarker, blood eosinophils. High blood eosinophils identify a group of patients with COPD who are at risk of frequent exacerbations and who are likely to respond better to treatment with inhaled steroids. So the concept, treatable traits and biomarkers, is already here. Of course, there are many others, but the concept is already recommended by GOLD. Now, let me share with you some still unpublished data, which I ask you, please do not reproduce or quote. I think that this might give you a good taste of what treatable traits might look like in real life. This is an analysis of more than 11,000 participants in the novelty study, which is a global study in real practice, primary care, allergology, and pulmonary clinics. And this study included almost 6,000 patients diagnosed of asthma by their attending physician, almost 4,000 patients diagnosed by their attending physician of COPD, and more than 1,000 patients diagnosed as asthma and COPD, or ACO, if you want. In this database, large database, we analyzed 30 treatable traits in the pulmonary, extrapulmonary, and behavioral, environmental, social domains I mentioned before. You might say, why did you look for these 30? Well, these are first frequent treatable traits. Look, non-reversible airflow limitation, bronchodilator reversibility, PRISM, frequent productive cough, and so forth, obesity, cachexia, anemia, osteoporosis, smoking, occupational exposures, frequent reliever use as a warning sign. These are available in this database. There may be others, but these are 30 frequent and available treatable traits. What did we find? Well, here you have the prevalence of these 30 treatable traits, pulmonary, extrapulmonary, behavioral, environmental, in these 11,000 patients in real life around the globe. What you see is that the prevalence varies very much according to the specific treatable trait. No surprise, in our respiratory cohort, almost 50% of the patient had non-reversible airflow limitation. Bronchoreversibility, 16%, chronic bronchitis, 34%, emphysema, 22%. But look at this, anemia, only 2%, osteoporosis, 3%, gastroesophageal reflux, 6%. What does this mean? This means that there are a number of treatable traits which are more prevalent than others, and therefore that they need to be looked for more carefully than others. It does not mean that the others are not important. If the patient has anemia, that might be important to treat, but it's really not that frequent. In contrast, many others are much more frequent. We look at the relationship between these 30 treatable traits, pulmonary, extrapulmonary, and behavioral, and the prevalence in patients diagnosed of COPD or asthma. And these blue cells identify those traits which are highly prevalent in those individuals diagnosed by the attending physician of COPD, not surprisingly. Non-reversible airflow limitation, emphysema, anemia, comorbidities, and smoking. So these are traits which are almost diagnostic of COPD. In orange, those traits whose prevalence was very high in asthma, not surprisingly again. Nasal sinus polyps, non-allergic rhinosinusitis, allergic rhinosinusitis, other allergies of T2 high. These are particularly prevalent in asthma. The important message in this slide, however, in my mind, are in the white cells, because all these white cells, all the treatable traits identified by white cells, were equally present in patients with COPD or asthma. So if you look for them, irrespective of the diagnostic label, you might find them, and you might treat them, which might have an important impact on the clinical outcome of the patient. Finally, we doctors work always, every single day, by pattern recognition. We establish diagnosis based on the present or absent of certain traits. So we were interested in this analysis in looking on how the mind of a physician works. What are the present treatable traits and the absent treatable traits that a physician consider to establish a diagnosis of asthma, COPD, or asthma and COPD? What we found was this: if these traits were present, reversibility, bronchiectasis, T2 high, allergies, and all of these were absent, emphysema, smoking, non-reversible airflow obstruction, these were highly associated to a diagnosis of asthma. Again, the white cells were not specifically associated to a diagnosis of asthma. When you do the same analysis in COPD, you'll find exactly the opposite. Many of these traits were present in patients with COPD and absent in patients with COPD. And when you look at asthma and COPD, there are no blue cells. So there are no absent traits. The diagnosis of asthma and COPD is a kind of an alluvial diagnosis. Everything counts, which speaks about, in my opinion, the non-specificity of this diagnosis. So how can we do this? So some years ago, 7 years ago, even at about the same time we were starting to talk about treatable traits, my friend William McNee in Edinburgh, in Scotland, the UK, and myself published this concept. You might have read it, the COPD control panel towards personalized medicine in COPD. And in this assay, we propose that we need in our computer a sort of control panel with different markers about severity, activity of disease, impact on the patient, and eventually omics biomarkers. We were not yet talking about treatable traits. It was some years before treatable traits, but the concept is exactly the same. Now, with electronic health records, it'd be relatively easy to have a control panel that informs the attending physician on these markers, these variables, or the presence of some treatable trait and the treatment that the patient is receiving for that trait. So in conclusion, the strategy based on the recognition and treatment, if available currently, as I said, of treatable traits is agnostic to traditional diagnostic label. It doesn't matter. I mean, we should stop arguing about asthma versus COPD or ACO. And aims at providing precision treatment to each individual patient suffering chronic airway disease. Gold already recognizes and recommends this strategy. The example is inhaled steroids prescription based on the persistence of exacerbation despite appropriate bronchodilator treatment, a treatable trait, and the level of blood eosinophil, a biomarker. Finally, there are many treatable traits in the pulmonary, extrapulmonary, and behavioral social domain that deserve investigation and treatment if possible. Some of them are particularly prevalent in patients with what we call asthma or COPD, but many are equally prevalent in these across these two traditional diagnostic labels. So with this, I thank you for your attention, and I'll be happy to answer any question you might have. Thank you.